Our focus is your gastrostomy and J-tube feeding. So this reminds us that you have several ways of feeding, and it is not only your nasogastric tube that is used for feeding. So you also have your gastrostomy, and then you also have your J-tube. Your J-tube is of course your jejunostomy tube. Now for our expectations for this course or this topic, we expect that you will be able to differentiate the gastrostomy and the jejunostomy tube according to the anatomical site, its indications, and placement procedures. Second, to enumerate the equipment used and the complications related to gastrostomy and jejunostomy. And the third one is to identify the nursing responsibilities performed in gastrostomy and jejunostomy. Now, class, if I would look at gastrostomy and Jejunostomy, what do you call the tube that is inserted to the stomach of the patient? The tube inserted to the stomach of the patient. What's the term for that? Mm-hmm.
J-tube, sir.
Uh-huh. Is it your gastrostomy, guys, or is it your jejunostomy? Okay, that would be your gastrostomy tube. Okay, so gastrostomy tube for that matter. Now, class, these access is surgically created. In other words, it is done by the physician, it is done by the surgeon. And one of its primary purpose is to serve as feeding. Okay? Now, you need to be aware that NGT feeding is only appropriate for short-term type of feeding. If we know that, for example, our patient had an esophageal problem, or if our patient had an esophageal burn, and then the entire esophagus was already removed, so we know that the patient could not have the NGT feeding. So we need to go to gastrostomy. If we know that our patient is having problems, let's say for example related to stroke, and we know that our patient will be at high risk for aspiration for long period of time, again longer periods of time, we would need a gastrostomy tube or jejunostomy tube. Your NGT supposedly is only ideal for short-term usage. So class, it is the preferred mode of delivery for your enteral nutrition longer than 4 weeks. So your cutoff there is 4 weeks. Okay, now let's talk about your gastrostomy specific. Class, your gastrostomy specifically is indicated for patients with esophageal atresia. It is indicated for patients with esophageal atresia. Sir, what is esophageal atresia? Class, when I talk about atresia, just think that in atresia, there may be narrowing, class, or it is also possible, class, that the esophagus is not attached to one another. Okay, there is a narrowing in the point of the esophagus, or the esophagus is not attached from top to bottom. Usually, dear students, your esophageal atresia is congenital in origin. In other words, upon the birth of the child, it's already there. So that's one reason I would need a gastrostomy tube. Now, you might be wondering, sir, upon childhood, it's already there. Can the child survive until adulthood? Yes, they can. Okay, in fact, it is through the gastrostomy tube that they will be able to survive, class, until adulthood. When I talk about esophageal atresia, you have the three C's. Okay, class, your three C's are as follows. So you have your coughing, you have your choking during feeding, and unexplained cyanosis. So the three C's are coughing, choking, cyanosis. Okay, those are the three C's of your esophageal atresia. Another indication is your tracheoesophageal fistula. Now, if you would look at this, you have your esophagus and then you also have your trachea. Okay, this is your esophagus, this is your trachea. Recalling your anatomy, you know that your trachea would be leading towards your lungs. That would be leading towards your lungs. If my patient has a fistula, dear students, a fistula is an abnormal opening between the esophagus and your trachea. Okay? Or class, actually, it's any abnormal opening between two organs. In this case, the abnormal opening is between the trachea and then between the esophagus. Now, if there is an abnormal opening between the two, what do you think would happen? What do you think would happen to the food intake that is present in the esophagus? Anybody? The possibility is that the food intake will proceed to your trachea, and your patient would have aspiration. because food should not be in the trachea. It is the air that should be in the trachea. So you're increasing the risk of your patient for aspiration. Now, could we have NGT for this one? We could, but since we foresee that there will be a long-term use of a feeding tube, gastrostomy tube would be recommended. Okay? Now, it's also preferred for comatose patients. Why is it preferred for comatose patients? Because the gastroesophageal sphincter remains intact usually among comatose patients. Okay, it remains intact among comatose patients. What do I mean by that? Class, recall that from your esophagus going towards your stomach, you have your gastroesophageal sphincter. Okay, the sphincter here has the purpose to prevent the food from the stomach to have an influx going to the esophagus. Again, the gastroesophageal sphincter is intended or made to prevent the reflux of food from the stomach towards your esophagus. And class, if your patient has coma, usually this gastroesophageal sphincter is still working. Usually, the gastroesophageal sphincter is still working. So, that means that we can still use your gastrostomy. In cases, dear students, that the gastroesophageal sphincter is not already working, what we are doing is that we are doing the jejunostomy. Okay, we are doing the jejunostomy. Okay, why? What do I mean by that? If the esophageal sphincter is not working, and then we still proceed with gastrostomy, the tendency is that the food product that comes in here, the gastric chamber, would still go back to your esophagus. It would still flush back or backflow to your esophagus, which still leads to the risk for aspiration. So, if the gastroesophageal sphincter is not intact, the best tube to be chosen is your jejunostomy tube. The best tube again is your jejunostomy tube. Now, your gastrostomy tube could be inserted surgically, endoscopically, or fluoroscopically. Okay, class, when I say endoscope, usually, okay, there is just a tube inserted through the mouth of the patient, and then class, that tube will be going towards the stomach of the patient, and then from that, you will be inserting the tube, or the doctor will be making the incision to make your gastrostomy tube. Okay? Class, when I say fluoroscopically, that's usually with the use of X-ray, and then the doctor will be asking the patient or the surgeon maybe would prescribe for barium in a barium swallow, and then successive X-rays are being taken to check if the tube is already in the place where it should be. Usually, from my experience, we are doing it endoscopically and surgically. Okay, endoscopically and surgically. Now, jejunostomy. Jejunostomy is indicated if your gastric route is not accessible. Okay? Meaning the route is not working, meaning the route is the stomach could be damaged, okay? Or also to decrease the risk for aspiration. Because between the two, gastrostomy and jejunostomy, which would have a higher risk for aspiration? Which would have a higher risk for aspiration? Is it your jejunostomy or is it your gastrostomy? Class, it is your gastrostomy that would have a higher risk for aspiration. Okay, it is the gastrostomy that would have higher risk for aspiration. Now, this one is placed surgically using your PEG. No? Okay, class, your PEG is percutaneous endoscopic gastrostomy. Okay, so class, gastrostomy man nagyapon tawag, no? Okay, because the tube used there is just like your PEG, or it could be inserted radiologically. Now, if it is surgical, class, one intervention is that the doctor would be suturing that in place. Okay, that needs to be sutured in place. And then class, radiologic examinations is also done to confirm for the presence or the placement of your tube. Now, your PEG tube is percutaneous endoscopic gastrostomy. And when I talk about your PEG tube, it is a feeding tube placed into the stomach. So class, that's directly into the stomach. If you would look at the nursing interventions, once you know, class, that the tube is properly sutured in place, we do not usually counter-check anymore for the placement of the tube. So you don't need to do the one that we did in our NGT, wherein you will need to inject air and then check for gurgling sounds. Okay, that's not anymore needed. What you would just check is for the placement. What you would just check, class, is the appearance of the tube externally. And then if you know that the tube is properly placed, you don't need to do the checking already of the placement. Okay. Now, much thinner jejunostomy extension tube is passed through the PEG tube into the jejunum. So class, this is why the PEG is used interchangeably between your gastrostomy and jejunostomy. Because what happens is that in your jejunostomy, dear students, in your jejunostomy, the tube is actually passing through the PEG tube also. However, class, the tube is ending, or the end of the tube is placed in the jejunum. Okay? So for example, class, if this is your esophagus and then that's your stomach with the some hole there because of your gastrostomy, and the class, this will be your duodenum, jejunum, and ileum. So sometimes, class, the PEG tube, okay, would also be the one leading towards the small intestine. Okay, so depending on the preference of the physician and depending on the case of your patient. Okay, so sometimes that happens. Now, class, placement is verified using X-ray upon the first insertion. On the first insertion, class, the placement is verified using your X-ray. Okay, take note of that. Now for the that we will be needing for our procedure for feeding. So you have your 60 ml syringe, you have your graduated container. Class, your graduated container, when we say graduated container, that's basically a container with markings, okay, of how many ml is that. Then a glass of water, a prepared formula. The formula, class, in our case here in the Philippines, is usually accomplished by the nutritionist dietitian or the dietary department. Then you would have your clamp, your gloves, your protective sheet, and then you will have your internal feeding bag and tubing, and then you will also have your your enteral, feeding pump, which is optional. Okay, so class, this is your 60 ml syringe. Okay, these are your graduated containers, glass of water. This is the formula. Usually in our setting, you would see something like milky or yellowish like because those are osterized tube feeding. In other words, those are usually mixture of fruits and vegetables which are osterized and given to your patient. Then class, you would have your clamp. Class, the clamp would be here already, part of the tubing. And then you would have your gloves. Okay, class, if you're doing the wound dressing, preferably you will need to have your sterile gloves. For feeding purposes, class, the textbooks would actually vary. But it's a clean procedure. Okay, it's a clean procedure. No need actually for a sterile gloves if you would look at the references in fundamentals. Okay, then you would have your protective sheet and then the feeding tube and bag and then enteral feeding pump, which is optional. By the way, this is the feeding pump. Okay, class, the feeding pump could regulate how many drops per minute will be going towards the patient. That is if your patient would have continuous feeding set up. Because there will be instances that patients would have a feeding every 4 hours. There will be instances that the patient would have continuous feeding to run for 12 hours. Now, the care of your G and J tube. Dear students, irritation of the enzymatic action of your gastric and intestinal juices occurs. Okay, look at that one. The picture, class, on this slide actually indicates an infected gastrostomy tube. That's not how it's supposed to look like. Okay, that's not how it's supposed to look like. But with the constant irritation of your enzymes, class, from your gastric juices, take note, you have gastrostomy. So meaning the tube has direct access towards the stomach. And then as what we have learned, is stomach acidic or basic? Is stomach acidic or basic? Stomach is highly acidic, meaning the acidic substance of the stomach has a direct access to the skin already. And with that direct access, class, and with the leakage around the tube, there may be maceration and pain. Okay, class, maceration is just like your ulcerations, and then there will be pain. Now, if your patient would complain, because usually in the clinical setting, this one is covered by a dressing. We are placing a gauze there, no? Imagine a 4x4 with a cut or slit, and then we wrap it around your gastrostomy tube. If your patient would complain of pain, don't just say, "Ma'am, that's natural. Ma'am, we expect that to happen." Okay? Now, so if that happens, if your patient is complaining of pain and irritation around the gastrostomy tube, don't just say, "Ma'am, that's okay, that's expected." You need to assess the area. Because once there is redness, you need to inform the physician so the proper management would be done. In some cases, class, the gastrostomy would need to be sutured again or resutured. Okay? And in other cases, it might need to be pushed towards or pushed forward. In other cases, class, the balloon inside needs to be reinflated. Okay? In such a way, class, that the acid of the stomach would not be going towards the skin of your patient. Okay? That may be as simple, but there are a lot of patients having these complications in the clinical setting. Now, what would you do for the care? You wash soap and water, and then you could have your chlorhexidine gluconate daily, PRN, to remove any incrustation. When I say incrustation, dear students, those are the secretions which dried up. Okay, and then later on, these secretions would become crust-like. Then you would like to remove them. Okay, so class, the solution that you can have is soap and water or 2% chlorhexidine. Okay, in some instances, there are surgeons who would not even recommend for the use of soap. No, some surgeons would just actually use your saline for irrigation. Because class, if you're using strong soap, the tendency is that the skin will also be irritated. Okay, so be careful with the soap. Now, for the soap and water, you need to rinse it well and pat dry. If it is chlorhexidine, just allow it to air dry. Okay, on the right of the slide is an example of the chlorhexidine product that we commonly use for wound care. Now, next, what do? You apply dressing, the thin gauze or foam. And then you need to have a new sterile dressing every 8 hours. Sir, every 8 hours? Yes, guys, to ensure the cleanliness of your gastrostomy tube. Normally, you would expect that there is scant serous drainage present at the site for a few days post-insertion. So class, when I say serous drainage, usually you would have something like blood-like, something like whitish material with a mixture of blood. That is expected, no? Serous to serosanguinous, that is expected. However, if your patient is already having purulent discharges, you need to be alarmed. Okay? First day post-op, pag may serous discharges, serosanguinous, okay. But the next days, let's say, for example, after 5 days, if that continues, you also need to be alarmed. Okay? Take note of that. Now, if there is purulent discharge, class, the purulent discharge actually signals pass. Pag sinabi kong pass, you're warning there or you need to be cautious because that's already an indication of infection. Okay, indication of infection. Now, after the drainage ceases, the site may be left open. Okay, once class, okay, the drainage stopped, the site may be left open. In other words, there's no more gauze or dressing that needs to be done. If you would actually look at the gastrostomy tube class, there is some cover there that is being used. No? Okay, it's like a cover that covers the access, and then that is where you are inserting the tube that you use for feeding. So once class, there is no drainage already, that usually happens at around 7 to 10 days post-operatively. Okay, 7 to 10 days post-operatively. So what could possibly happen, class? You can remove already the dressing of your patient. Okay. Now, wash the area around the tube. Then, evaluate the skin at the exit site. Then you apply dressing. Again, class, it's normal to have the serous drainage at the site for a few days and then rotate the tube once daily. Now, what's the purpose of rotating the tube once daily? It is for us to prevent skin breakdown and buried bumper syndrome. Okay, class, your buried bumper syndrome is because of excessive traction of the G tube. Okay, don't too imagine or don't think too much about that for you to understand what is that. Okay, this is class what happens in your buried bumper syndrome. If this side class, okay, or if this side of the tube is buried deeply on the skin of the patient, your patient would have the buried bumper syndrome. That's why it's advised to rotate that site from time to time. Okay? Plus, this is how your gastrostomy tube would look like. This is the tube already under the skin of your patient, going towards the stomach of your patient. This is the part that we can see as nurses when we are feeding our patient. Okay, class, this is the safety plug that we remove whenever we will be feeding the patient. That's the safety plug that we will be removing whenever we are feeding the patient. Now, what do? Class, you need to watch out for these complications. The common complications that may possibly occur are wound infection or cellulitis at the exit site. Okay, now there may also be bleeding. There may also be leakage. There may be excessive tightness of external retention bolster, which would lead towards your syndrome earlier. Then you would also have your tube dislodgement. Tube dislodgement, class, is less likely to happen unless your patient moves a lot during the time of feeding. Okay? Now, again, wound infection. If your patient is having sign of redness, erythema around the insertion site of the tube, refer right away to the doctor. Those are early signs of infection. Do not wait for fever, because once your patient is already having fever, that's already a systemic sign. It might be a late sign already of infection in this case. Okay, take note of that. Now, other than watching out for signs of infection and bleeding, you also need to perform your vital signs and MIO. So class, you tape and suture. Class, the taping and the suturing is actually done by the physician. Okay, of course, it is the physician who's doing the suturing. In this case, guys, okay, what you will be doing as nurse is to ensure that there is adequate tension and security on the part of the suture and the tape. In other words, you're ensuring if the tube is attached properly to the patient. Because class, excessive tension, when I say excessive tension, there's too much pulling or the suturing is too tight, the tape is too tight, it may lead to excruciating pain on the part of the patient. Now, sir, earlier you mentioned that if the patient excessively moves, there's a possibility of dislodgement. If the tube, my dear students, would be detached, you need to report it right away. Okay? We are not the one licensed to reinsert the tube. If you would want the tube to be reinserted, that will be your surgeon who will be doing it. Because class, if that will not be reinserted, the tube can close in 4 to 6 hours. Okay, 4 to 6 hours. And class, after the surgery, we give the first fluid nourishment soon after the tube insertion. Okay, that is at around after 30 minutes class or within 30 minutes after tube insertion. But what we are doing there is that we are only administering sterile water or NSS of 30 ml. Okay, so 30 ml only of sterile water or plain NSS. Next, you wait for the doctor, okay, for to start the formula feeding. Usually, class, that happens within 24 hours after insertion. Okay, so within the day after the gastrostomy tube was created, we can start feeding. In fact, class, if the GI functioning of the patient is already okay, what I mean by that is that if your patient is already having flatus, or if the doctor could hear bowel sounds, they would usually prescribe to have the feeding within 8 to 12 hours. Okay? Now, flush the tube. Class, again, when I say flush the tube, you just need to pour some water there on the tube before you have your feeding ongoing. Okay, before you would have your feeding ongoing. So class, the flushing of the tube would be done before and after the bolus and intermittent feeding and medication administration. If you would actually read from the textbook, if I have 10 medications that I am giving separately, what I should be able to do is that flush with saline first. And then after that, 10 ml of medications. Then another saline. Then medications. Flushing again. Then medications. Okay? That's how frequent the flushing should be done. But if you would look at it in actual practice, you need to consider the case of your patient. If your patient would have chronic kidney disease, if your patient would have congestive heart failure, you need to be careful on the frequency of the flushing because your patient might experience fluid retention. Your patient might experience fluid retention. Now, class, this is the procedure. So, of course, we gather all the equipment to be used for the procedure. You explain the procedure to the patient. So, in your return demonstrations, if ever you will be doing demonstrations on this, do not just narrate. Okay, instead you will say, I am gathering all the equipment to be used for my procedure. Then you go to your patient, you greet the patient, you identify the patient. Always remember that when you are identifying the patient, you are not supposed to ask the patient, are you Juan de la Cruz? That's a very inappropriate question to your patient. What is the best way then for you to identify your patients? Okay? You may do checking of the ID band, but how would you be able to confirm that it is indeed your patient? What would you do, or what would you ask your patient? So class, you ask your patient to state their name. Okay, you ask the patient to state their name. So your class, it's just like this. You hold the patient, you ask the patient, ma'am, can I hold your hand? I would just be checking your ID band. And then class, ma'am, please state your name. And then you compare what she's saying to the ID bracelet and to your patient's chart. You are not supposed to ask the patient, are you Juan de la Cruz? Because if the patient class is unconscious, semi-conscious, your patient may have the tendency to answer, yes, I am Juan de la Cruz. Okay, semi-conscious. Because if unconscious, your patient is unable to answer. Provide privacy, and then you perform your hand hygiene and wear your gloves. Plus, you prepare the measured amount of formula or medication in an appropriate container. Okay? Then, you elevate the patient's bed to a high Fowler's or semi-Fowler's position. What is the purpose? Why do I need to elevate the patient's bed to that position? So class, your high Fowler's position or your semi-Fowler's position is to prevent, okay, the aspiration of the fluid going to the lungs of your patient. Okay, that's the purpose. Now, class, you need to place protective sheet under the tubing just to prevent the area from getting wet. And then class, you need to remove the cup or plug from the feeding tube. And then aspirate stomach contents with the syringe. Class, the purpose of aspirating the stomach content with the syringe is for us to know whether there are still a lot of food products that were not digested in the stomach. If, for example, there are 50 to 100 ml of fluid in the stomach, we document it and return on the patient's stomach. Again, we need to return it to the patient's stomach, okay, the fluid that we have excreted. But class, if the fluid is more than 100 ml in the stomach, we need to inform the physician. We need to inform the physician before we do our feeding. There will be instances that the feeding would be placed on hold because the patient might not be digesting the fluids or might not be digesting the food products properly. Okay? So again, for the aspiration of stomach contents, if less than 100, return. And then class, you can proceed with your feeding. If more than 100, refer to the doctor before you continue the feeding. Sir, will I still return if more than 100? Yes, class, you still return to your patient because that gastric content contains a lot of acid and it also contains a lot of potassium. So we don't want that to be out of your patient's body. Okay, don't want that to be out of your patient's body. Next, we need to note the amount of the residual withdrawn and inject gastric fluid back into the tube. Okay, this is what I'm talking about. Then connect the enteral bag tubing, pump tubing to the jejunostomy tube. Okay, so class, earlier, remember there's a plug there. So you remove the plug and then that's the time that you attach the tube. With the infusion controller, that is if you are using class a feeding tube regulator, with the infusion controller, you need to purge the tubing of the air and attach it to the feeding tube. In other words, what do we do, class? Okay, if we already have the feeding here hanging and this is the tube left with air, what we do is we run the feeding through the tube without first adjusting or attaching it to the patient. Okay, without first attaching it to the patient. What's the purpose? So that class, we will minimize air entry to the patient. So that we will minimize air entry to the patient. Then you open the regulator clamp of the enteral tube to allow the formula to flow. And then you adjust according to the recommended flow rate by the doctor and according also to the patient's tolerance. Plus, as what I've observed, no, and also even the textbooks would tell you this, class, if the feeding is cold from the refrigerator, your patient would complain of stomach pain by the time, class, that the feeding would arrive on their gastrointestinal tract. Okay, they would complain of stomach pain by the time that the feeding would arrive to their stomach. Why is that so, dear students? Because, class, your cold is an irritant to your stomach. Again, your cold is an irritant to your stomach. Okay, then after that, so what do you need to do first to prevent cramping? Okay, class, what you need to do is to warm it on room temperature. warm on room temperature. If you are in the settings abroad class, there will be microwave-like equipment which can be used to warm these products. Then, as I mentioned earlier, flush. Okay, you need to flush the tube with 50 to 60 ml of water after each feeding to ensure the patency of the tube. So again, gastrostomy, we are not very worried of placement. We are worried of patency. Unlike in NGT, our main concern will be placement over patency. In this case, our main concern is just patency. Okay? Then we pinch the tubing and remove the enteral bag, the controller tubing, and then the clamp or cap the feeding tube. Okay, class, before you clamp again, you need to pinch the tubing. Then, you need to leave the patient in semi-Fowler's position for 30 minutes. What's the purpose of this position, class? To allow for the food product inside the stomach of your patient to go down to the intestines of your patient and to facilitate nutrition and absorption. Okay, to facilitate nutrition and absorption for that matter. Then, discard the soiled supplies in appropriate containers, wash hands, and then document in the patient's record. These are the items that you need to document. Okay, in your charting, what could you do? Focus, okay, for gastrostomy, tube feeding. Data. Patient with gastrostomy, no swelling, no redness noted. Placement, check. The tube is placed in the gastrostomy area or the gastric area. There is 50 ml of aspirated fluid. Tapos, action. What would you do on the action? You write there, fed or infused with 200 ml of feeding formula via patent gastrostomy tube. Tapos, amount of water administered. If there are no medications given, you could say 60 ml of flushing done before and after feeding. And then class, as your R, feeding well tolerated, maintained on high Fowler's position for 30 minutes. Okay, and then that will be your charting if ever you're doing your focus charting. Class, for your references, these are the references that I use, and the slides are actually originally from Professor Aguirre. So that's it for this discussion.